and on the ethics committee at St. Vincent Charity Hospital here in downtown Cleveland. She is the author of Last Rites, A Catholic Perspective on End-of-Life Decisions, and she is currently working on a second book about moral decision-making. Please join me in welcoming Dr. Christie.
Well, I think every death panel needs diversity, and I sit here today as diversity in terms of being the only woman on the panel, the only short person on the panel, probably the oldest person on the panel by a good bit. But I think the reason I'm here today, at least the reason I was asked to be here today, was to speak from the Roman Catholic point of view. It's easy to do so today because hot off the presses, the Catholic bishops have just passed a revision of one of the ethical and religious directives that govern Catholic hospital practice. That came late yesterday, and I am fresh with the copy this afternoon if anybody is interested. But to give you just a quick 5 minutes, 500 years teaching in 5 minutes, overview of the Catholic perspective. Catholic teaching generally highlights principles. And from the point of view of end of life, the principles that are highlighted again and again and again in documents that come out of the Catholic tradition are human dignity, God's ultimate dominion over human beings, life and death, and a sense of community. And all of these play into the teachings that will come out of the Church on end of life. Human life has a value, but human life is not an absolute value. So giving your life for a friend or sacrificing your life for someone else would not be considered wrong. Therefore, life is not an absolute value that has to be preserved at all cost. Conclusions from these principles regarding end of life would be that Catholic teaching says that one cannot directly kill. I cannot put a pillow over grandma's face or inject her with something that will put her to death quickly. I cannot use direct killing, even if my purpose is to use the killing as a way to eliminate pain. So killing can't be a means to an end, even if the end looks like a good one. I must have an intent to kill with the ideas that's a means. Secondly, the Catholic Church is very clear that both suicide and euthanasia would be morally wrong. Now, this is not always clear because in the Catholic tradition, it has always been very much the case that if someone is in great pain, and if whatever medication you give them to relieve pain and suffering, which is a good, then even if that medicine were to hasten death, which for the most part it does not, we know, but even if it were, that would be an acceptable practice. The point is no direct killing, no intention to relieve pain by the killing. Stuart mentioned in passing the idea of direct killing versus letting someone die, and I think psychologically there is a big difference. But in terms of the moral issue from the Catholic point of view, if I do not start a treatment because it is futile or because the patient believes it to be too burdensome, even financially burdensome, that would be morally correct. But I can also morally remove treatment that is no longer effective. Psychologically, it's going to be a lot harder, but morally it would be equivalent. Finally, I could mention the Shivo case that obviously kicked off a lot of discussion about feeding and hydrating people who are dying. The directives have pretty much kept their traditions of you can, if there is too much burden, you do not have to nourish and hydrate people. We can talk more about that later. I think that's sufficient for starters.
Thank you very much, Steve. Our cleanup hitter on the panel is David Simpson. David has been the Chief Executive Officer of Hospice of Western Reserve since 1985. Founded in 1978, its present daily census is 1,400. I think David mentioned maybe 1,500 patients now, and is comprised of more than 1,000 volunteers and 840 paid staff, making it the largest hospice in Ohio and one of the top 10 nationally. Regarded as a leader in quality end-of-life care, Hospice of Western Reserve also operates a 42-bed hospice residence, the Elizabeth Severance Prentice Community Bereavement Center, and a hospice institute, and serves 5 counties operating from 10 community sites. David himself has been active in promoting quality end-of-life care through publications, presentations, and service on national and regional boards. He is the recipient of a number of awards, notably the National Heart of Hospice Award, recognizing his leadership qualities in the hospice field, and the Mandel Center for Nonprofit Organizations Leadership in Nonprofit Management. He is a 1966 graduate of Ottawa University in Canada and has his master's degree from Kent State. David is a licensed social worker. Please join me in welcoming our cleanup hitter, David Simpson.
I hope I don't strike out. I think that preparation for our own death is an integral part of a wellness program. Indeed, the likelihood of dying well is significantly diminished if there is little or no preparation for death's unavoidability. Probably the most important aspect of such preparation is a conversation or conversations with a trusted friend or family members. The second most important dimension is the preparation and execution of advance directives. In Ohio, we have the living will and the durable power of attorney for health care. Hospice of the Western Reserve has a guide to assist in preparing these documents. It's one thing to be appointed as a healthcare proxy for someone, but it's quite another to inform the proxy about how to interpret interventions you would want under differing circumstances and varying scenarios. For example, under what conditions would you want or not want intravenous feeding, tube feeding through the nose or the stomach, artificial hydration, CPR, antibiotics, surgery, dialysis, blood transfusions? And how might your wishes about those things differ according to different circumstances? Suppose, for example, you had a terminal condition, or suppose you were in a coma from some other condition, or you have dementia, or you had a stroke, or you happen to be in one of those conditions because of an accident. The intended purpose of our guide is to stimulate dialogue and to develop within the proxy a very strong sense of confidence that they do know your wishes well enough to represent them should that need ever arise. However, an important consequence of using the guide is that it also helps one clarify these things for oneself. And this is crucially important because, more often than not, one makes one's own decisions about these things. The proxy's role is only legally permissible when your decision-making capacity is gone. So it's in the area of identifying what one would want in these circumstances that people sometimes think they would want to have medicine in order to end their life. They would want assistance with suicide. Surveys tell us that more Americans than not support the legalization of assisted suicide. And here are their reasons in rank order. First one, altruism, love. I don't want to use my family resources and empty the coffers. I don't want to be a burden to the care, to expecting being cared for by a loved one. Second, fear of loss of dignity. Acceptance of care receiving may be very challenging, especially personal care. Third, the fear of pain and the desire to avoid it. Fourth, a personal conviction, a political belief, a belief in autonomy, a belief that it is my life to control, it's my right to decide to live or die.